Hi, so this lecture video is on nutrient homeostasis, where we'll really be kind of doing an overview of metabolism and how it's primarily regulated by the hormones insulin and glucagon. So to start, I want to talk a little bit about the anatomy. So the pancreas, all right, is located behind the stomach, and it's a retroperitoneal structure. And the pancreas is actually, a fairly complex organ in that it has both endocrine and exocrine function. Its exocrine function I'll be talking more about in the gastrointestinal lectures, but its endocrine function, it helps us to regulate our glucose, fatty acids, and our amino acid metabolism. And so there's actually discrete groupings of cells referred to as the islets of Langerhans, which let me highlight that over here. So here's the islets of Langerhans. And these little groups of cells, they have different kinds labeled as either like an alpha cell or a beta cell, a delta cell, there's F cells and so on. There's several others. And in these little discrete regions, these particular cells, like alpha cells, for example, will release the hormone glucagon. Beta cells in this region will release insulin, and the delta cells will release something called somatostatin. Now, these islets actually anatomically don't make up most of the pancreas. In fact, that's mostly made up for the exocrine function of the pancreas. But you'll still find anywhere between 1 to 2 million of these islets, and they'll be very responsive usually to ingestion of nutrients, so that they can ready the body for intake of food and storage and so on. Now the pancreas here in this cadaver image you can see it's highlighted in pink there, and you'll notice its positioning again. They've cut away the stomach so you can see it, and what you're seeing is over here, let me highlight this for you a little bit, this structure right there, that's actually the duodenum. And so you see the little hook in the duodenum there, and you'll notice that the pancreas has sort of discrete structures here. So if you look at the bottom over here, that's the head of the pancreas, and that's kind of tucked nicely into the duodenum. And then connecting the head to the body, this is the body over here, connecting that would be the neck. And then at the far end over here is referred to as the tail, and the tail kind of tucks itself into the liver, the spleen. So this is the spleen that the tail kind of sits into. So the tail points towards the spleen, the head actually is tucked into the duodenum there. And another important feature of the pancreas is that its blood supply, when it's releasing its hormones into the bloodstream, it has a sort of a first pass effect, if you will. It passes directly into the portal system to the liver. Okay, so our basic metabolic fuels are glucose, right? So we have essentially we ingest carbohydrates, lipids, and proteins. And then in the process of digestion, which we'll discuss in detail in the GI lecture, we break them down into component parts that are usable by the cells. So namely things like glucose. So that would, in glucose, we normally keep a fasting level somewhere between 70 to about 110 milligrams per deciliter. On average, you'd see probably somewhere around 90 milligrams per deciliter if blood glucose homeostasis is normal. And I say fasting meaning between meals. So you haven't just recently eaten a meal, because that would cause an increase or a transient increase in your glucose levels. Lipids, so usually those are broken down to fatty acids and triglycerides, and so they'll circulate in the blood, and they're primary nutrient for a lot of tissues. So we tend to think of glucose as being a primary nutrient, but in fact fatty acids are used by many different tissues. Things like cardiac muscle, skeletal muscles use fatty acids in abundance. Amino acids derived from the proteins, so we can get that from the diet, okay, or the breakdown of proteins in muscles, since muscles contain a lot of protein. And in fact, when we break down some of the muscle protein, we release those amino acids into the bloodstream. They can go to the liver, and then the liver will take those amino acids and actually convert them into glucose. Otherwise, if it's coming from the diet, the amino acids could actually be taken up by the muscles to produce proteins. And so what we do with any of these nutrients, say glucose or fatty acids or amino acids, whether we're storing them or breaking them down and releasing them into the bloodstream for the tissues to use, really depends on our state of whether or not we've just eaten, right? We're in a fed state, whether we're in a fasting state, really between meals, or in a state of what we call starvation, which is really not eating for several days. And then lastly, ketone bodies there. And the ketone bodies, they're produced from metabolism of fatty acids in the liver, and they will also serve as nutrients for tissues and sort of subserve nutrients for muscles in the beginning, and then maybe later on for neural tissue. And we'll talk more about that in the upcoming slides. Okay, so let's talk about the sort of the basics of metabolism after a meal. Okay, so just after a meal, like just following a meal, what happens to the nutrients, all right, that we've just ingested? So as I mentioned before, the primary components of food are really going to be carbohydrates, lipids, and proteins. And so you can see that over in the column over here. So there's our carbohydrates, our lipids, and our proteins. The carbohydrates in the GI tract are primarily broken down into glucose. Okay. Now that glucose, all right, once it enters into the body here, really the hormone requirements, all right, following a meal, the hormone that you're going to see in abundance is insulin. So insulin levels will rise in response to rising glucose levels, rising fatty acid levels, and rising amino acid levels. Okay, and these are all really the breakdown products from digestion. And so insulin levels rise, and in general, insulin, it'll act on multiple tissue types, as you'll see, and its job is really an anabolic one. It's going to drive those nutrients into the cells, and some of those nutrients from ingestion will be used right away just for energy purposes, and then the rest of it will be stored. And so that's insulin's job, is to make sure that it gets into the cells, into the tissues, and gets stored. And so what you're going to see, so for example here, if we have glucose, you'll notice that the CNS, or the central nervous system, all right, like the brain, for example, doesn't require any insulin to take up glucose and utilize that for energy. Okay, and that's actually an important feature. However, muscle, adipose tissue, and liver, for example, which are the next three down here, okay, they all require insulin for certain metabolic processes. So, for example, in skeletal muscle, it'll utilize insulin so that it can take up glucose for energy usage, as well as storage of glucose in the form of glycogen. So skeletal muscle is one of the main sites in our body which stores glucose as glycogen. The other one is the liver. Adipose tissue utilizes insulin also to drive glucose into the cell so that it can utilize that for energy, but also to convert some of that glucose into fatty acids and triglycerides that can be stored for later. And then the liver also utilizes insulin. It doesn't require insulin to get glucose into the cell. However, it responds to insulin to promote glycogen synthesis. And in fact, this is again a storage form of glucose that resides in the liver cells. And this is actually our primary storage for glucose in our body, because when the liver stores glucose as glycogen, when it breaks it down, it's going to distribute that glucose to the rest of the body when we need it. Whereas in the skeletal muscle, it stores glucose as well, but when it breaks it down, it utilizes the glucose for itself. In addition, the liver is also going to be using or converting glucose into fatty acids and triglycerides that it will ultimately use for storage. Now, when it comes to the fatty acids, same thing, we're going to be talking about insulin. Now, as fatty acid levels rise after a meal, you'll notice that the skeletal muscle, for example, doesn't necessarily need insulin to take up the fatty acids and use that for energy. But adipose will use it, and it'll use that for energy, but it'll also use these fatty acids and convert them into triglycerides for storage in the adipose tissue. And the liver will also take up the fatty acids, maybe use some of that for energy as well, and it'll also convert some of that into triglyceride synthesis, again for storage as fat. And then the last one is protein, which is broken down into amino acids. And the amino acids are taken up by skeletal muscle in the presence of insulin, and that promotes protein synthesis. Insulin also inhibits protein degradation, which makes sense to make sure that we have more of an anabolic effect. Okay, so that was the fed state. So in the fed state, the primary hormone is insulin, and insulin's job is really, you know, an anabolic one and a storage one. And however, following a meal, say 2 to 3 or even 2 to 4 hours after a meal, as glucose levels start to go down because insulin levels have risen, what you're going to see is some other hormones, what we call counter-regulatory hormones, start to rise. And so an important feature of our body is that we actually have to maintain tight control of the glucose in our blood, the glucose levels, because our brain and our red blood cells, or I should say our neural tissue and our red blood cells, they require a certain amount of glucose because they can't really utilize other substrates. And I'll get more into that in the next slide. And so they really require a sort of a good homeostasis of glucose. And so during a fasting state, we don't want the glucose levels to continue to be utilized and then drop out of our normal range, say below 70 milligrams per deciliter, because that could actually be very detrimental to our health and could lead to, you know, things like coma and death and so on. So it can be very, very dangerous. So the body has adapted to being able to survive between meals as well, based on the storage that we just gained from the fed state. So for example, if we take the tissue, the adipose tissue over here, okay, so that's our fat, right, which we've stored a lot of energy in there in the form of triglycerides, for example. When glucose levels start to go down, insulin levels go down, and glucagon, which is really the counter-regulatory to insulin. So insulin drives glucose into cells. Glucagon actually brings glucose or raises the glucose levels in the blood. Epinephrine can also raise blood glucose levels. And again, that would be in the presence of low insulin levels here. So what you have now is the adipose tissues actually going to break down some of its triglycerides and release that in the form of free fatty acids. Okay, and the destination of those free fatty acids are really for most of the tissues. Like I said, central nervous system and red blood cells really require glucose. They can't use fatty acids. Okay, they don't use it, so they don't have the machinery to do so. So they require glucose, which is why we have to regulate that. So what we do is we break down the fatty tissue into, or the triglycerides in the fat tissue into free fatty acids that can be utilized by most of the other tissues in the meantime, so they're not using up the glucose that the brain and the red blood cells need. Okay. And then in the skeletal muscle during fasting, all right, again, here this would be, say, epinephrine and low insulin levels, but not necessarily glucagon here. We'll see an increase in the amino acids in the blood. And the reason is it's breaking down the proteins in the skeletal muscle and releasing the amino acids to the blood, which get taken up by the liver. And the liver takes those amino acids and it uses it for gluconeogenesis, which just basically means you're making glucose out of the amino acids. Okay. And but again, amino acids aren't the only substrate for gluconeogenesis, but it's one of the primary ones in fasting here, at least in the first 2 to 4 hours. Now, liver gluconeogenesis, which we were just talking about, all right, that's influenced by glucagon, epinephrine, and again in a low insulin state. And so what happens is the liver now is actually secreting glucose into the blood. And so it's doing this because it's taking some of the amino acids that it's been getting from the skeletal muscle. And that helps maintain glucose levels for the central nervous system and red blood cells, for example, so that they have an adequate amount. Meanwhile, the other tissues are really utilizing more and more fatty acids. And then the liver will also have glycogenolysis, all right, or genolysis. And this is the breakdown of glycogen. And if you recall from the previous slide, we store glucose in the form of glycogen in the liver. And then what happens is glucagon and epinephrine in a low insulin state will influence the liver to break down its glycogen stores, and then the liver cells do not use the glucose from that. Instead, it gets released into the bloodstream, and that helps to maintain glucose levels as well. So the liver is really important here. It's undergoing gluconeogenesis, so it's converting other things into glucose like amino acids, and it's also breaking down its glucose stores so that it can release that to the body as well, to make sure that the central nervous system and red blood cells, for example, have adequate nutrition. In the meantime, the other tissues primarily will start to take up things like fatty acids. Okay. So I want to kind of give you just an overview of this fasting mechanism and kind of take you through some of the players that are involved in this. So here, this is fasting. We're talking really about 2 to 4 hours. This is something that would occur really between meals, so to speak. Okay, or even in some cases in an overnight fast, so from the time you have dinner to the next morning when you have breakfast. So over here, draw your attention to this right there. So in the blood, in a fasting state, we have a low, a drop in our glucose because the glucose levels have been dropping after the fed state because insulin levels have been driving that down. Since the glucose levels are going down, insulin levels are also going down, and glucagon levels are rising. So those two are kind of counter-regulatory, as I mentioned. And so what we have is something referred to as an insulin-glucagon ratio, so I over G. So this is an insulin-glucagon ratio. And so usually in a fed state, there's a lot of insulin and low glucagon, so it's a very high ratio. In a fasting state, insulin levels drop and glucagon levels rise, so the ratio is smaller. Okay. So in this fed state, here's what's happening. We're going to take a look at the liver, since the liver is one of the primary regulators here. So we're going to need to maintain glucose levels. Again, we're maintaining glucose levels because we really want to help out the red blood cell over here and the central nervous system. And so in the glucose, we have glycogen. That's the storage form of glucose. So during fasting, glycogen starts to get broken down, and that glucose gets released into the bloodstream so that both the central nervous system and red blood cell can use them. All right. Now, that's the only form at this point that the central nervous system can be using it. It requires this glucose. Again, it doesn't store its own glucose, and it can't utilize fatty acids. Red blood cells, same problem. They can't utilize fatty acids. They require glucose. But red blood cells lack a mitochondria. And because they lack a mitochondria, they produce lactate, okay, from glycolysis. Lactates, all right, will leave the red blood cells here, which I circled in red, and go back to the liver. The liver will actually take that lactate and it'll convert that into glucose, and that's called gluconeogenesis. Okay, right? So gluconeogenesis can convert amino acids into glucose as well as lactate. And so it converts that into glucose, which can then be released into the bloodstream, all right, and resupply the red blood cells. So it's a nice sort of recycling there. Now, at the adipose tissue over here, what's happening in the fasting state is the triglycerides start to be broken down into free fatty acids and glycerol. So they get released into the bloodstream. So here's our free fatty acid down here. And then there's glycerol over here. Glycerol I also circled in red because glycerol goes back to the liver and it's converted into glucose. So we use lactate, amino acids, and glycerol as substrates for gluconeogenesis to produce glucose. So all of this helps us maintain glucose levels so that we can keep the brain and the red blood cells satisfied. Now, at the same time, the free fatty acids that have been released can go to something like this, which is the skeletal muscle over here. All right, so they can go to the skeletal muscle and then be used for energy, which takes some of the burden off of using something like glucose, for example. So they use more and more free fatty acids. The free fatty acids will also be utilized by the liver as well. Okay, so the liver will take the free fatty acids and use that for energy because it's not going to be using the glucose that it's trying to supply the rest of the body with. So it starts to use its free fatty acids, and in the process of using fatty acids for energy, it usually gets backed up free fatty acids. And what happens is it'll start to produce this KB here, which is ketone bodies. So it actually converts free fatty acids into ketones. Okay. Those ketone bodies can also be used by many of the tissues for energy, which actually includes the brain as well. So it's going to use these ketone bodies, so that'll be another energy substrate for, say, muscles and whatnot. And at the same time, during this fasting state, protein is being broken down primarily from muscle because that's where there's a lot of protein stores. You'll have the amino acids released to the bloodstream, go back to the liver, and then that'll be converted into glucose as well. All right, and what happens is because Amino acids are one of the main substrates for gluconeogenesis. You produce a lot of urea. So what happens is you take the nitrogenous compounds, which are the metabolic byproduct of protein metabolism, and you produce urea, and then the urea gets excreted by the kidney. So the point is here that in a fasting state, in 2 to 4 hours or so, the amount of urea in the urine would actually increase because you're using more amino acids as a substrate for gluconeogenesis. All right. So in the overall picture here, you have a decrease in your insulin and a decrease in your glucose levels. We want to prevent glucose from dropping too low, so glucagon levels start to rise. And what happens is, to maintain those glucose levels, the liver is required to convert substrates like amino acids, glycerol, and lactate into glucose, which can then be utilized by the brain and the red blood cells, as well as breaking down the storage of glycogen. In the meantime, things like skeletal muscles and so on will use free fatty acids for energy, as well as ketone bodies that are also produced by the liver. Now, in starvation, okay, so now we're talking really about days. Let's say 2 to 4 days instead of 2 to 4 hours. So 2 to 4 days. In this case, what you're really looking at is the adipose tissue. Glucagon levels will still be elevated. Epinephrine will also be playing a role, and it will still be in a low insulin state. So that really hasn't changed much. They'll continue to break down triglycerides into free fatty acids. And those free fatty acids will be used by pretty much all tissues with the exception of, again, the central nervous system and the red blood cells. And for the liver, they'll take those free fatty acids and use it for energy for itself, as well as producing more and more ketones. So it produces these ketone bodies, which again get released into the bloodstream and can be used as energy for other tissues. And the hormones needed, again, with glucagon in a low insulin state, central nervous system and the muscles can actually use ketones for fuel. Now, what happens, and what I want to kind of clarify here, is that as the liver starts to utilize more and more free fatty acids and converting it into more and more ketones, ketone levels start to rise the longer somebody fasts. And there's an important transition here where skeletal muscle, which makes up a large bulk of the tissue of our body, utilizes a lot of ketones as well as fatty acids. But there's actually a metabolic switch where it stops utilizing ketone bodies for energy and just strictly starts to use fatty acids instead. Which means ketone levels start to rise even more because the skeletal muscle is not utilizing them during this starvation period. This is beneficial because that means more ketones that can be used by the central nervous system. So this is important because this actually puts less stress on trying to maintain glucose levels because now there's an abundance of ketones. So there's a little bit of a switch. There's less reliance on glucose because now there's an abundance of ketones. All right. Now, lastly, the liver and the kidneys are the only sites that can release glucose into the blood to meet the needs of the central nervous system in general. But those needs in a starvation period start to go down as it starts to use more ketones. So let me show you on the next slide. So we're saying we're fasting for 2 to 4 days. So here, again, glucose levels are low. All right, insulin levels will be low, glucagon levels will be high. All right, so our insulin-glucagon ratio would be low. And in this case, it would be even lower. So here is basically the same diagram I showed you as before, but one of the differences is the glycogen is depleted at this point. In fact, glycogen under sort of normal standard resting conditions, the glycogen storage would really only last 10 to 12 hours in a given day, which really kind of gets you through the night, essentially. Right? If you stop eating at 8 o'clock at night and you don't eat breakfast until 8 o'clock the next morning, that's about 12 hours. Your glycogen levels are probably depleted at that point. Or if you're vigorously exercising, they may go in a matter of several hours instead. So it's not an endless supply there. So again, that would already be depleted several days later for sure. So we can't get any glucose that way. All right, but you'll notice the amino acids here. All right, we start to utilize less and less amino acids for gluconeogenesis to make glucose because our reliance on glucose actually goes down. Our reliance on the central nervous system for glucose actually starts to go down, which is why you see this little dotted line over here. Okay, the reliance on glucose by the central nervous system goes down because of that switch off that I talked about, the ketone bodies. Remember, the free fatty acids continue to go up and up and up because we keep utilizing that storage during starvation from the fats, and that free fatty acids goes to the liver. When it goes to the liver produces more and more ketones, or these ketone bodies. Okay, those ketone body levels start to rise, and again, they could be utilized by the muscle tissue, but during starvation, the muscle stops using ketone bodies and strictly starts to use free fatty acids instead. So that means ketone body levels rise, which gives ample amounts of substrate to the central nervous system to be able to utilize that. So it starts to utilize more and more ketones, which takes the reliance of glucose or reduces the reliance on glucose, which means we don't need to do as much gluconeogenesis anymore, which also means we don't need to break down proteins in the muscles for amino acids. This is good for us, especially in states of severe starvation, because it preserves the muscles so that, in an evolutionary kind of way, we can continue to kind of forage or hunt or move or even breathe with our diaphragm, so we can help maintain our body's homeostasis, which requires this muscle. So it actually helps us to preserve our muscle at that point. And you'll also notice down here, if we're using less amino acids for gluconeogenesis, then we're not going to be producing as much urea. And during states of starvation, in fact, if you were to measure urea in the urine, you would see it's reduced. Okay, so let's talk a little bit more specifically now about insulin and glucagon's activities. So we'll start with insulin. It's secreted from the beta cells, as I mentioned, and it's secreted during and after a meal, right? So we mentioned that. So that's when the glucose and amino acid levels are rising and the fatty acid levels are rising. Insulin levels will rise along with that. And so that stimulates its release, right? So we have an increase in plasma glucose levels will stimulate its release, an increase in plasma amino acid levels. Oral intake of food stimulates it, and which again, in terms of the autonomic nervous system, the parasympathetic, the rest and digest portion of the nervous system, will activate the release of insulin as well. To inhibit insulin's secretion, usually that would be sympathetic nervous system. So again, that fight or flight response would kind of turn off digestion processes, and low blood sugar or hypoglycemia would be something that would inhibit insulin secretion. In terms of insulin synthesis, you have it's produced in the cells, of the beta cells, as proinsulin, and as it's sort of packaged and stored inside those beta cells, it's cleaved into insulin plus its connecting peptide, or C-peptide. And it has a half-life of about 10 to 25 minutes, and it's, again, as I mentioned earlier, secreted into the portal vein, which means that insulin flows through the liver first. And that's an important concept because the liver will actually extract 50 to 60% of the insulin out of the bloodstream before any of that insulin makes it systemically. So, either half or a little more than half actually, or of the insulin actually gets extracted in that first pass through the liver. Again, I mentioned this in an earlier lecture about insulin when I was giving an introduction to the endocrine system and its C-peptide. And so remember, every insulin molecule has a C-peptide molecule. When it's cleaved, that means that when it releases insulin, it releases C-peptides in what we call equimolar amounts. And since 50 to 60% of the insulin gets extracted passing through the liver, the C-peptide does not. If you were to measure insulin levels in the blood, systemic blood, you wouldn't get the idea of how much is actually released from those beta cells. You wouldn't get the full amount, about 40% of it actually. And but the C-peptide, which doesn't get extracted at all, the C-peptide would be actually a marker of how much insulin was actually being released from those beta cells. And that could be useful because that tells us how much insulin the beta cells are producing, and you can actually track that production over time if somebody's, say, pre-diabetic or diabetic. And especially helpful in a diabetic patient who might be taking exogenous insulin. and you want to measure how much insulin that their beta cells are actually still producing, you'd have to look at the C-peptide amount. Okay, so here what I want to do is I want to demonstrate what or how our beta cell responds to glucose. All right, so I'm going to take this as our beta cell is square here, and then I'm going to draw in its membrane, all right, a ATP dependent potassium channel. So I'm going to draw a little potassium with a little sub ATP there. So this is an ATP dependent potassium channel. And over here, this is our glucose receptor, which is a, I'll put it down here, I guess I'll put it over here. It's a GLUT2, so a glucose transporter 2, and our potassium, our ATP dependent potassium channel. Okay, so what happens here is this. As we have glucose can enter through this glucose transporter. All right, so that's our glucose. All right, so glucose enters into the cell via the GLUT2 transporters, or the glucose 2 transporters. And when inside these beta cells, glucose actually gets broken down into, or gets metabolized into ATP, ultimately. Okay, and so we produce the ATP from that glucose, and as that takes up all this glucose and produces more and more ATP, the ATP, increase in ATP actually, I'm going to draw like a little bar here, it inhibits, I'll draw a little negative sign. The ATP actually inhibits the ATP dependent potassium channel, so it blocks that. The ATP dependent potassium channel, what happens is when it closes off that, it changes the membrane potential of this cell. All right, and so what happens is this the membrane potential actually depolarizes. So when we inhibit that, the cell depolarizes, and what you have nearby here, I'm just going to draw it over here. All right, are voltage gated calcium channels. So that's a voltage gated calcium channel. So when you inhibit this, all right, this depolarizes and activates these voltage-gated calcium channels. So calcium comes inside the cell. And when calcium enters the cells, it can bind to calmodulin, for example. All right, and upon binding to calmodulin, it causes the release of the stored insulin inside the cell. So insulin is then released. So in this way, glucose comes into the cell, gets degraded into ATP. ATP inhibits this potassium channel, which causes the cell to depolarize. The depolarization activates voltage-gated calcium channels. Calcium comes in and actually triggers the, ultimately triggers the release of insulin. So insulin is then excreted into the bloodstream. And this will be continuous excretion based on the amount of glucose that is there. In fact, what you have is also voltage-gated potassium channels that'll reset the membrane potential, but as long as glucose keeps coming into the cell, it'll continue to produce ATP, which will continue to inhibit that ATP-dependent potassium channel, and it'll continue to depolarize it over and over and over again, continuing to release glucose, continuing to release insulin. Now, what they found through various studies is that orally administered glucose has a much more profound effect in causing release of insulin than does giving IV glucose. And they actually refer to this as the incretin response. And incretins are just compounds that are secreted from the GI tract that actually sensitize beta cells so that they release more insulin in response to digestion. So we usually have a more profound oral response, and this graph is what you're seeing with that, is that you have over here in the first box is, again, over time, this is insulin secretion, and the dashed line over here means oral glucose, and the solid line is IV. And you'll notice that you see that the oral glucose far exceeds the IV glucose secretion. However, if the maximum insulin secretion is reduced, like let's say you have 50% impairment in your ability to secrete insulin, you'll still have a better oral response, but it's closer to the IV response. And then lastly, if you have say 75% impairment or so of your insulin secretion ability, which you might see in a diabetic, for example, you'll notice that the oral glucose and the IV glucose are almost matched at that point, even though both are essentially reduced. But we lose that ability to have a much stronger GI response to insulin release. So the actions of insulin, I've kind of already alluded to this, but let's review it again here. So more specifically, the insulin on the tissues will bind to something called a tyrosine kinase receptor. And I have an image of this on the next slide, which I'll go over. The ultimate effect, though, is going to lower blood glucose levels, right? And so it's going to increase insertion of glucose transporter 4 on adipose tissue as well as skeletal muscle. It's going to decrease hepatic glucose production. So the liver is going to reduce its production of glucose. As I mentioned earlier, one of insulin's main job is to promote storage and synthesis and decrease glucose levels. So it has to, inhibit the liver's ability to release glucose as well. So it inhibits gluconeogenesis, glycogenolysis, and promotes glycogenesis and storage. It also inhibits amino acid release from the muscles, so that can't be utilized for gluconeogenesis. It increases adipose lipid synthesis. So again, as I mentioned earlier, it's going to increase storage, right? So fatty acids and triglyceride synthesis and uptake as well. It increases hepatic lipid synthesis and reduces ketogenesis. So it allows the liver to produce more lipids, more fatty acids and triglycerides, which it then can transport to the tissues for storage, like the adipose tissue. This helps to reduce ketogenesis because it's not going to be utilizing as much of the fats now for ketogenesis. And increases muscle protein synthesis and inhibits its breakdown or its catabolism. And then finally, the last one I just want to underline because it's not one that I've reviewed yet, but insulin can also increase the uptake of potassium by most cells. And clinically, we utilize that, especially if somebody is, in a certain state of hyperkalemia. We also need to know that if we give them insulin, potassium levels could drop. Okay. So this cartoon here is going to give you a kind of a demonstration of the actions of insulin. So we have, to start at the top here, this here is our tyrosine kinase receptor. It has these alpha subunits that are outside the cell, which bind to insulin. And then you have these beta subunits, 2 beta subunits, that have these tyrosine residues that become what they call autophosphorylated when insulin binds to the alpha subunits. So insulin binds to alpha subunits, beta subunits become phosphorylated on their tyrosine residues, and this activates the tyrosine kinase of this receptor. Remember, a kinase phosphorylates things. So inside the cell, one of the substrates that it will phosphorylate is something called an IRS, or an insulin receptor substrate 1. And so IRS1 then will act as like a second messenger inside the cell, and it can produce all sorts of effects depending on what type of cell that we're talking about. So for example, here, this is the L stands for the liver. So in the liver, insulin's effect is to inhibit, the little negative sign stands for inhibit gluconeogenesis and inhibit ketogenesis, right? Because we don't want glucose or other energy forms being released from the liver. In the liver and adipose tissue over here, you'll notice that it's inhibiting lipolysis or the breakdown of fats, and instead it's promoting, which is the little positive sign, it's promoting the storage and synthesis of fatty acids and triglycerides. Okay. And here M is for muscle. You notice that it's promoting the uptake of amino acids, and it's promoting protein synthesis while inhibiting proteolysis or the breakdown of proteins. And then in the liver and the muscles, it's promoting glycogen synthesis, okay, and it's inhibiting glycogenolysis, right? So we can have the storage form of glucose. And then again, it's increasing potassium uptake in many different cells. And then over here in the muscle and adipose tissue, insulin increases the number of glucose transporters on the surface, primarily the GLUT4, So it increased the number of GLUT4 transporters on the surface, so it can increase its uptake of glucose. Okay, so we talked about insulin. So the counter-regulatory hormone, as I mentioned, is glucagon, which is secreted by those alpha cells. And this would be released between meals, right, during the fasting or even the starvation period. And it primarily stimulates the liver. And so its stimulation for secretion are a decrease in plasma glucose levels, right, because it's counter-regulatory to insulin. An increase in the plasma amino acid concentration, which is interesting, and I'll come back to that. An increase in parasympathetic and sympathetic stimulations, which can modulate its release. Exercise, stress, and starvation can all cause an increase in glucagon levels because, for example, exercise will utilize more energy and more glucose, and so therefore glucagon helps to maintain those levels. Any time of stress, as we mentioned, even with like cortisol, for example, is another one that helps to keep glucose levels elevated. Glucagon will do the same. Starvation. So in a state of starvation or in a state of fasting, you'd see elevated levels of glucagon for the reasons that I mentioned. Inhibition of the secretion of glucagon is increased plasma glucose levels, so that will inhibit that. Its synthesis is half-life is about 10 minutes. It's formed in what they call a proglucagon and cleaved to a glucagon and it's transported to the liver where that's its main target. So one thing I just want to address before I move on is that we noticed that with insulin is increased in response to glucose, amino acids, and fatty acids, and so on. Basically all the breakdown products of our diet. Glucagon, being sort of the opposite of insulin in this regard, you would expect it to be released in a state of low glucose, low amino acids, and so on. But you notice that in one of the examples that I gave just now, right, that the amino acid level here, if it's increased, can also cause an increase in glucagon, which means that in certain circumstances, you could have an increase in insulin as well as an increase in glucagon release. Now, it seems a little sort of counterintuitive to have both of those go up since they're sort of anti to each other, but this would occur in sort of specific examples. So let me give you an idea of where this might happen. So if we ingest a normal, well-balanced diet with carbohydrates, proteins, and lipids, then you primarily just see insulin levels rise. So under most normal conditions with normal diets, that's the pattern: an increase in insulin and a drop in the glucagon. However, let's say we have somebody who has a very low carbohydrate diet and a very high protein diet. What happens in this scenario is you're still releasing insulin. Okay, insulin is going to respond to that increase in the amino acids. Insulin is still going to carry out everything that we talked about. It's still going to drive glucose into cells and amino acids and so on. However, if the person ingested a lot of protein and very little carbohydrate, that means the glucose level didn't really rise that much after the meal. And if insulin levels rise because it's responding to the amino acids, it's going to drive the glucose into the cells as well. And that can cause the glucose levels in your blood to go very low and you can become hypoglycemic. So in this case, the glucagon will rise in response to the rise in amino acid. And what that does, that helps to counter the drop in the glucose from the insulin, because glucagon's effect on the liver is to cause an increase in the production of gluconeogenesis. And so it can actually cause a predominant pathway in the liver to cause gluconeogenesis, to increase the output of glucose from the liver to counter the actions of insulin in that particular situation. So that's one example of how that might work. If the person would have ingested carbohydrates along with the protein, the glucose would inhibit the glucagon levels and those levels would be low. As far as the actions of glucagon, again, that's actions primarily on the liver. So it's going to increase gluconeogenesis, increase glycogenolysis, which is going to break down that storage, increase lipolysis, so break down some of the fats within the liver, and increase ketogenesis. And so it's promoting ketogenesis in this case. So, another form of energy. And then the adipose tissue, it does have some action on adipose tissue. and its actions there would really be to increase lipolysis, so to break down fats into free fatty acids to be used for energy. And the last one I want to talk about in those islets there, the last type of cell is a delta cell or a D cell, which releases somatostatin. Now, I've talked about somatostatin in some of my other lectures, in some of my other videos, where we talk about it in the hypothalamus, where somatostatin inhibits growth hormone release, for example. In my GI lecture, I talk about somatostatin inhibiting nutrient digestion and absorption. Here, though, the pancreatic somatostatin, it seems to have maybe like a paracrine effect where it's affecting the local cells there in the islets to modulate the release of glucagon and insulin, because it can actually inhibit the release of both insulin and glucagon. And so there seems to be a modulatory role, which is not entirely clear exactly how that's done. Okay, so kind of to wrap up this lecture, I have to really kind of touch on diabetes, especially since I've already mentioned it several times in some of the previous slides, and since diabetes is so prevalent in our society today. So, and in fact, it's the most prevalent metabolic disease in the world. And disruption of the metabolism due to the hyposecretion and or inaction or loss of insulin. So in other words, we have all these counter-regulatory hormones like epinephrine, cortisol, growth hormone, glucagon, and they all serve to increase glucose levels because we're constantly metabolizing. And so therefore, we would use up all our glucose and those levels would drop and be very dangerous for us, especially for our central nervous system. And so we have a lot of counters built in to help us maintain that level. Whereas really in the reverse direction, when it comes to driving glucose levels down, we don't have as many options. It's really insulin. And that leads to a lot of problems when our ability to respond to insulin or produce insulin is decreased, as it is in diabetes. And so some of the symptoms you might see in somebody who's diabetic, again, this would be somebody who's not really responding to insulin or not producing it. I mean, we can't drive glucose into the cells, right? The nutrients aren't getting inside the cells as appropriately as they should be. And so you can end up with polyuria, which means excess urine output. And that's in part due to the fact that if I have more glucose in the blood, when that gets filtered in through the kidney can't extract all the glucose, okay, and pull some of that back into the bloodstream. Instead, it ends up in the urine, and it acts like an osmotic agent and can draw water with it. And so you sometimes can see an increase in urine. Polydipsia means there's an intense thirst, again, because you're becoming dehydrated from all this high urine output. And polyphagia, an increase in hunger because essentially, the cells are starving for more nutrition that they're not receiving. And, if we're to look at the blood levels, you'd see the blood glucose levels would be elevated. Okay, you'd see glucose possibly in their urine, and you'd see the production of ketones because they start to rely on breaking down fatty acids and the liver producing ketones in order to get the energy that it requires. So there's different types of diabetes mellitus, and there's type 1 and type 2, and this is actually just a very surface level review of this, but there's like subtypes to this as well. But in type 1 diabetes mellitus, otherwise known as insulin-dependent diabetes mellitus, or IDDM, makes up anywhere between 5 to 10% of cases in the US. And insulin is always used to treat type 1 diabetes because the problem in type 1 diabetes is that they don't produce insulin from their beta cells. So they'll need insulin either via injection or an insulin pump, and they constantly have to monitor the blood glucose levels and control their diet and so on. And the way this comes about for some of these patients is it can be hereditary, where you might see it early on in life. There's also an autoimmune component to this as well, where the immune system attacks the beta cells and destroys them, so they can't produce any insulin. And usually this disease is seen maybe somewhere in early adolescence or before the age of 40. Okay. If as I said in the last bullet there, if somebody happened to be susceptible and they're infected with a certain virus, for example, they could develop autoantibodies that would destroy those beta cells, and then they would require insulin to help maintain their glucose levels. In type 2, which is referred to as like sometimes referred to as a non-insulin dependent diabetes mellitus, but that's not entirely true, because type 2 diabetics, most of them at some point or another will actually require insulin, and I'll explain that in a second. But this is going to be most of the cases of diabetes that you see, 90 to 95%, and this is usually over the age of 40. Still, there is this inherited association with it. And really, in this case, it's not as much in the beginning about the failure to produce insulin as a failure of the target cells to respond to insulin. However, if the tissues aren't responding to insulin, the beta cells start to produce more and more insulin to the rising glucose levels. The problem with that is that this starts to burn out the beta cells as well, and over time, as they're trying to churn out more and more insulin, they may stop making insulin altogether. So this is why it leads to the loss of insulin over time. So again, risk factors are heredity. It's usually over the age of 40. Obesity is a major factor to insulin, reduced insulin sensitivity. Ethnicity does play a role, like Native American or Hispanic and Asian. Oftentimes with this, it's treated with a weight loss program and exercising. Because interestingly enough, exercising muscle doesn't require as much insulin. Excuse me. Loss of muscle mass causes difficulty with the regulation of glycemia as well, because again, exercising muscle doesn't require insulin and can utilize some of that glucose. Also, they've seen that reductions in weights can also increase insulin sensitivity. If it's necessary, which it is for many, you also have to use glycemia-lowering oral medications like metformin, for example, sulfonylureas. Interestingly, sulfonylurea is a secretagogue. It actually acts on the beta cells, and it blocks the ATP-dependent potassium channels that I spoke about. And if you recall, blocking that ATP-dependent potassium channel is the same effect inside the cell to release insulin. So it blocks that channel, causes depolarization, which causes the release of insulin. So it helps to release insulin from beta cells. And again, 90% will need to use insulin at some point when the beta cells stop functioning. So for the pathogenesis, for type 2 diabetic, for example, the cells can absorb the glucose. They're less responsive to it. This doesn't affect the central nervous system or the red blood cells per se, because they don't require the insulin. But most of the other tissues will start to rely on fat and protein for energy needs. And this is where you might start to see things like weight loss in the diabetic and weakness, because the proteins are being broken down. Remember, the body doesn't realize that the glucose levels are high. It just thinks it assumes they're low because it's not getting any glucose. And so it'll break down protein and try to utilize the amino acids for gluconeogenesis, which can actually exacerbate the problem and increase glucose levels even further. Fat catabolism, so you're going to see a lot of breakdowns of free fatty acids, and then that's going to produce a lot of ketones. So the person can get ketonuria, so a lot of ketones in the urine, glucoseuria and glucose in the urine, and this promotes an osmotic diuresis, so water follows that. Loss of sodium and potassium. Sometimes you can lose some of these electrolytes because they can bind to the negatively charged acids produced from the ketones. Irregular heartbeats and neurological issues can ensue from this. You can get ketoacidosis, like in a type 1 diabetic. Ketones can actually decrease the blood pH, and as a result, you get things like deep gasping breathing, like Kussmaul breathing, what they call a diabetic coma if the pH drops below 7, and these can be deadly results. Oftentimes with diabetic ketoacidosis, we see that in a type 1, not really in a type 2. And this is, you'd see increased fatty acid promotes cholesterol and triglyceride synthesis by the liver. Because we're relying more on fatty acids, that means, the liver is going to produce more triglycerides in synthesis, and it's going to produce more lipoproteins. So the lipoprotein levels can actually start to elevate in diabetics. This has been associated and correlates with causes of atherosclerosis, which can affect blood vessels in the heart, in the brain, and everywhere else, like the kidneys. causing MI and stroke and kidney failure and so on. In terms of chronicity, you have hyperglycemia over long periods of time. This, especially if it's been uncontrolled or undiagnosed, particularly in type 2 diabetics. This leads to, neuropathy, right? Problems with, the neural signaling, cardiovascular damage from atherosclerosis, microvascular disease, kidney failure. Arterial damage and in the retina and the kidneys is very common in type 1, but can be seen in type 2 as well. Atherosclerosis leads to, heart failure, and that's more common in like a type 2. The diabetic neuropathy is really, it's nerve damage from lack of blood flow and lack of blood flow to certain regions of the body because of the microvascular disease can lead to erectile dysfunction, incontinence, poor wound healing, loss of sensation from an area, and a host of other issues, ischemia to the heart and brain and so on. Oftentimes with a diabetic neuropathy, with that loss of sensation, they have it in what they call a stocking glove pattern, meaning that it's kind of like a sock on the leg. It doesn't follow a dermatomal distribution like from just a specific neural disorder, but instead a whole area of the leg from the mid-calf down to the foot, for example, are classic areas, or the more distal regions of the extremities like the fingers and toes and so on could be affected by this. And oftentimes that's one of the things that's instructed to patients with severe diabetes and uncontrolled diabetes is to make sure to check their feet on a daily basis, because they start to lose sensation. They may not notice that they're stepping on tacks or glass or getting things caught under their nails and whatnot, and this can lead to infections, which can lead to gangrenous infections and so on, and it can get very deadly from there. So it's one of the things that we have to make sure patients check. All right. In summary, I mean, really, this regulating our glucose levels is important in both directions. We don't want to go too low or too high. But if it goes too high, it's more of typically a chronic issue, leading over time to things like atherosclerosis and so on, and artery damage, and ultimately, end organ damage. But these are not usually acute effects. This takes time to progress, and so it has a very insidious onset, and most people don't realize it. And this is why checkups periodically are important to make sure that everything's being regulated appropriately. On the other hand, if glucose levels drop too low and we don't have enough counter-regulatory to bring them up, that can be detrimental to our central nervous system very acutely and very quickly, to the point where it could turn into comas, seizures, and death very rapidly. Okay.